This program is brought to you by Emory University.
Morning, everybody. Happy Monday. We'll go ahead and get started. I'd like to introduce our speaker for this morning, Esther Kim from Vanderbilt. Esther did her training. She did medical school at Duke, went to Hopkins for residency, and then Cleveland Clinic for cardiology and vascular medicine fellowship. And since then, she has started a very productive career at with cardiology and vascular medicine in Cleveland Clinic, and recently moved to Vanderbilt, where she directs the Arteriopathy Clinic, and she's a national leader in the field of vascular medicine and vascular imaging. She has been a mentor and a friend to me over the past few years, and I've really enjoyed that relationship. Esther is going to be the national PI for the SCAD registry and is going to share with us her experiences with SCAD and teach us everything we need to know about spontaneous coronary artery dissection. So thanks everyone for being here. Thanks, Esther.
Hi, good morning, everyone. I just wanted to thank Brian and Dr. Taylor for the invitation. I'm really excited to be here at Emory, and thank you for coming to the talk. So I think that most of us have heard about spontaneous coronary artery dissection, but it's really becoming a little kind of popular. And you see it every once in a while on Twitter and these discussions that happen. And as Brian mentioned, we are starting a national registry, and so I thought I'd tell you a little bit about the potential collaboration we're going to have on this registry as well. I have no disclosures, and at my heart, I'm a clinician, so I like to kind of frame things around patient care, and so I'd like to show a few cases. This is a 33-year-old woman who was 11 days postpartum. I'll try to see if I can get this video to work. Oh no. Okay, look quick because it might disappear. She finished nursing her baby, later laid down, developed severe chest pressure, and I don't know if you were able to see that severe LAD stenosis that she had. For some reason, it's not showing the play controls. Look at the cath film quick because it might go away on the next one. This is a 42-year-old woman who had just finished an exercise class, felt faint, chest pressure, had some nausea, and then finally decided to call EMS, and she was diagnosed with an inferior STEMI, taken to coronary angiogram and diagnosed with that horrendous right lesion. This is a 46-year-old woman who was just driving down the street, developed chest pressure, drove herself to an ER, and was diagnosed with an anterior STEMI. And I think everyone recognizes that she's missing most of her LAD from the proximal vessel on down. This is a 61-year-old nurse who developed chest pain at work during a particularly stressful time. She came to the ER, was diagnosed with a non-STEMI, and was diagnosed as having atherosclerotic coronary artery disease. And I happened to come on service at that point, looked at her angiograms, and she actually had SCAD. So what is this strange disease, and why is it becoming so popular? So the first descriptions of coronary dissection were actually decades ago, and since then there have been many case reports, but in recent years there's just been an explosion of interest in terms of small single center studies, as well as case reports, continued case reports, and now starting with some multi-center registry data as well. So spontaneous coronary artery dissection is defined as being non-traumatic, non-iatrogenic, and it occurs because there's a separation in the coronary arterial wall with an intramural hematoma, which can be associated with an intimal tear, but does not always have to be. And the intramural hematoma causes compression of the arterial lumen, which results in myocardial ischemia and infarction. And so you can see here that we see this dissecting hematoma, and the true lumen of the coronary artery has been compressed by that intramural hematoma. So who gets SCAD? SCAD, very similar to fibromuscular dysplasia, primarily affects women. So 90% of cases will be in women. And the prevalence in the general population is very difficult to tell. But what we can tell from the published literature is that it probably affects 1 to 4% of all acute coronary syndromes. But if you look at women who are under the age of 50, about 35% of them will have coronary angiograms that have appearance that is consistent with SCAD. And this is work that Jackie Saw did in her institution in Vancouver. It's actually one of the most common causes of pregnancy-associated myocardial infarction. And troponin positive ACS is actually the rule and not the exception. Similar to other arteriopathies, such as fibromuscular dysplasia, it primarily affects middle-aged women. So based on these numbers, we think that SCAD is rare, but really, is it underdiagnosed? If we think further about who gets SCAD, these are the largest series in the world's literature. And so we have a lot of work to do. There's a Canadian cohort. Jackie has probably over 700 patients now in her Canada cohort. The Mayo Clinic has a registry, probably over 700 at this point, and there's a cohort in Italy as well. But this is the published literature, and they all seem to agree that it's primarily women. They're middle-aged when they present. They're primarily white, although there is probably some referral bias because it's the women who are able to seek second opinions that get included in these registries, although in Canada it is much more population-based. They tend not to have the traditional cardiovascular risk factors. So if you look at the prevalence of hypertension, hyperlipidemia, smoking, they're not as high as you would expect for patients who present with myocardial infarction. So who gets SCAD? Well, these are the faces of SCAD. This is a patient of mine from Cleveland Clinic. She was a nurse who was out with her friends, developed chest pain, and had a non-STEMI. This is my first patient at Vanderbilt, Jessica Biggs, whose story got published in the Vanderbilt newspaper, and I'll show you where Kath films. And she is a teacher who has taught her students what happens when she has chest pain. She has one who gets the nitro, one who calls the principal, and one who calls 911. So you can see this disease that affects these young women is completely life-changing and affects the people around them as well. And then this is Catherine Leon, who founded this patient organization called SCAD Alliance, and we'll be hearing more about that. But Catherine actually underwent bypass surgery shortly after having her second son. And that prompted her to start this patient organization. So when you think about SCAD, these are the people that you should be thinking about. And as I stated before, acute coronary syndrome with positive troponin is the rule and not the exception. Patients may also present with unstable ventricular rhythms, and they can also have cardiogenic shock from multi-vessel SCAD or significant LAD SCAD. Interestingly, you will see wall motion abnormalities very commonly on left ventriculogram during coronary angiogram, but if you check again 30 days to 90 days later, those wall motion abnormalities will actually go away sometimes, and sometimes they're stunning. That also improves when you look a month or more after. So why is SCAD underdiagnosed? Well, I think one of the significant causes of underdiagnosis happens in the cath lab, and that's because SCAD has variant presentation angiographically. So I think any cardiologist would recognize this type 1 SCAD, which is that double lumen appearance with dye staining. You can see the flap. But it turns out only about a third of all SCAD cases are this classic double lumen dye staining, dye hang-up appearance. There's also something called type 3 SCAD, which is really intramural hematoma. So we know that coronary angiography is luminography, and so when you have intramural hematoma without a flap, what you're going to see is just this smooth narrowing. And how do I know that that's not atherosclerosis? It's because we have OCT information to tell us that it's intramural hematoma, and as I'll show later, when you repeat images, these coronary arteries actually go back to normal appearance. The most common angiographic appearance of SCAD is this type 2 SCAD. And it's that example of that nurse that I showed you earlier, where the caliber of the coronary artery is normal and then becomes abruptly narrowed. And so whether it extends all the way to the apex or whether it returns to normal caliber, these are considered type 2 SCADs, and these are the most common. So if you see a patient who fits the right demographic profile and they have these very long, narrow lesions, think about SCAD. Turns out that SCAD actually primarily affects the LAD and its branches, but it can affect any coronary distribution. And about 10% of the time, more than one coronary artery is affected. So why do we get these variant appearances? So here is that type 1 SCAD that I think anybody can probably diagnose right away in the cath lab. Type 3 SCAD's a little harder because if this lesion were a little shorter, I mean, it could certainly be some atherosclerotic disease. So how do we differentiate if that is actually coronary dissection versus an atherosclerotic lesion? And what you can do is intravascular imaging either with IVUS or with OCT. And this lesion had this OCT appearance, which was intramural hematoma. And furthermore, 17 months later, this patient had repeat angiography and that vessel had healed. And you would not expect to see a normal caliber vessel if this were a fixed lesion from atherosclerosis. So why do we get these variant angiographic appearances? It's all whether or not the intima is intact. So if the intima is not intact and you have a tear, then you get that type 1 appearance. If the intima is intact and you have intramural hematoma with compression, you get that smooth narrowing that can be a longer lesion than atherosclerotic lesions. In terms of the acute management of SCAD, we have to remember that SCAD and myocardial infarction from SCAD is not the same as myocardial infarction from plaque rupture. And the tools that we have to treat acute coronary syndrome were actually developed for myocardial infarction with plaque rupture. And so the tools that we have, the medications that we have, are they beneficial or do they actually cause more harm if we try to use them acutely? So that segues into the in-hospital acute management of SCAD. And it turns out that about 80 to 90% of patients who have ACS from SCAD will actually demonstrate healing, and some with complete healing, if you repeat a coronary angiography even 30 days after their SCAD. However, the 7-day recurrent MI rate within the hospital is rather high. So 5 to 10% of patients will have symptoms and an elevation in their troponin sometime during the hospitalization. And for this reason, experts in the field advocate that these patients stay in the hospital for about 3 to 5 days. So even if they feel fine, are stable after cath, you would do a stent in an atherosclerotic MI and discharge the patient the next day. In a conservatively managed person with SCAD, or even a patient who's had a PCI, you would really consider keeping them because their rates of recurrence are high and the rates of potential complications are high. So this is the patient who had been working out, and you can see that she had a significant lesion in her mid-LAD, a type 1 SCAD, and you can see the dye hang up here. 30 days later, we actually repeated her coronary angiogram because this was such a narrow stenosis, and she had a large territory at risk, and she actually demonstrated significant healing in just 30 days. So how do we consider who to fix, and how do you think about SCAD in the acute setting? And I think this is something that a lot of institutions struggle with. So one way to think about coronary dissection is, one, you have to make the right diagnosis. So it's very important to sort of burn not just that type 1 appearance, but also type 2 and type 3, and have a high index of suspicion in patients who fit that demographic. If a patient has no high-risk features, and I'll talk about what those high-risk features are, really medical management may be the way to go, and patients do well with medical management. And when we think about risk stratifying patients, you can think of risk factors in terms of anatomic criteria and clinical criteria, and really a mix of both needs to be used to make the appropriate decision about whether to revascularize or not. So if you have a single vessel SCAD and it's a mid or a distal lesion, you could really consider medical management. However, if a patient continues to have ongoing ischemia, if they have a mid-vessel lesion, that's a point at which some people would consider percutaneous intervention. Certainly, if you've got a left main lesion or proximal to vessel disease, these patients should be considered for bypass surgery. And if they are clinically stable, however, so if you've got a circ and an LAD lesion, but they're clinically stable, you could certainly consider medical management, keeping them in the hospital, and taking a relook a little bit later. Thinking of clinical criteria, regardless of where the lesion is, if the patient has ongoing ischemia or certainly has hemodynamic instability in terms of shock or arrhythmic instability, one would really want to consider urgent revascularization, either percutaneously or with bypass grafting. But if the patient, regardless of the lesion, appears to be stable, then you can wait it out, really considering medical management. So it's a little complex, and it takes a lot of brains to kind of look at the angiogram and look at the patient. But I think what's important with these patients is a lot of times they just need a tincture of time to declare themselves and which way they're going to go and which way their lesions are going to go. So this is that 33-year-old woman whose calf I tried to show you earlier. She's got that really ugly proximal LAD lesion. They attempted intervention. And at the end of the case, you can see that while that proximal lesion was fixed, she has lost the remainder of her LAD as a result. So what are the outcomes with PCI in the acute setting? It turns out that they're really not that great. And why is that? Well, if you think of the intramural hematoma as like a tube of toothpaste, it's got some mass to it. And so when you have intramural hematoma, it's acutely filled with stuff, and you try to expand a stent right in the middle of that mass is like squeezing that tube of toothpaste. It has to go either out the front end or it has to go squeeze out the other end. And so what happens is all of a sudden you have a stent in the middle and you've got propagation of dissection going out towards the distal end of the vessel or even more proximally. And that can cause worsening obstruction. And this is a anatomic example of a carotid dissection, but this is what intramural hematoma looks like on this gross specimen. And you can see that this is the lumen that's been compressed. And you can imagine that when the interventionalist puts their wires and their stents into that lumen, you actually have to squeeze that intramural hematoma somewhere. And so that can actually cause propagation. Secondly, these patients develop spontaneous coronary artery dissection. And so there's probably some weakness in the artery or a susceptibility for them to develop spontaneous dissections. And so the incidence of catheter-induced dissection or iatrogenesis in these patients with this susceptibility is shown to be higher than in those patients who have atherosclerotic coronary artery disease. And then these patients also can present with distal lesions. And so when you try to open a balloon or put a stent in these very small vessels, it may not be very successful. And then finally, there's always that risk of not knowing where your guide wires are going when you're doing the acute intervention. So these are some of the reasons why short-term outcomes may not be so good with PCI, and I'm sure that some of the interventionalists listening to the talk have had their experiences with patients who've needed more and more stents as the case has gone on. But what are the published outcomes? So if we look at these three larger studies, we see that primarily patients are treated medically, and I think that as more current series get published, we'll see that treatment with medical therapy, the prevalence will go up. And PCI success rates are really terrible when you compare them to PCI success rates in atherosclerosis. So in this series, 43 to 73% of patients are considered to have success. But there's also some argument about how do you define success in SCAD, particularly in these long type 2 lesions. Does it really have to abide by that TIMI rule, or is it if the dissection length is smaller? So there kind of almost needs to be new definitions for PCI success in this special group of patients. As we talked about before, the rates of in-hospital MI are not insignificant and range around 5%. And for those who are medically managed, up to 8.5% ultimately requires some sort of PCI. And so that's why it's a good idea to keep these patients in the hospital long enough to see which direction they'll go. Luckily, in-hospital mortality up to now has been reported to be pretty low. So this is a publication recently that's come out trying to look at SCAD on a population basis. The national inpatient sample was queried from 2009 to 2014, and what they did is they took all female acute myocardial infarction patients who underwent coronary angiography, excluded those with iatrogenic injury, and then they matched patients with SCAD in a 1-to-2 ratio with patients who did not have SCAD using 55 covariables. And two important findings was that they found the overall prevalence of MI due to SCAD was about 1% in this population. And about 45% of women who have SCAD present actually with STEMI. And you can see that the mean ages here are 61 and 67. So a little older in the atherosclerotic group, however, older in general compared to the registry cohorts that I've shown you before. So when we look at this patient-based analysis, we see that over time on the x-axis and incidence on the y-axis, that the use of PCI really has declined over time in SCAD versus atherosclerosis, where it's remained stable. And if we look at in-hospital mortality, the rates have remained stable for atherosclerotic disease, but for SCAD, the mortality seems to be slowly declining. And in-hospital mortality for SCAD patients versus those with atherosclerotic disease was about 2.4-fold higher and was statistically significant. If we took that a little farther and stratified these patients into non-STEMI or STEMI and looked to see what effect PCI had on in-hospital mortality, it turns out that if you present with the non-STEMI, you had a 2-fold increase in in-hospital mortality, whereas if you presented with STEMI and had PCI, you had a 40% reduction in hospital mortality. So this is a national inpatient sample, and I really think we need to take this data with a grain of salt. As I've shown you in the first few slides, SCAD is a diagnosis that requires knowledge of angiographic appearance beyond that classic type 1 appearance with the dye hang up and the double barrel appearance. And really the classification of type 1, 2, and 3 SCAD was developed by Jackie Saw and published around 2012. And so really think that there's probably some underdiagnosis in this population sample. It's probably a little early to do this kind of general inpatient population-based analysis. We also note that the average age of the SCAD patient in this study is about 10 years older than registry patients. And so I really have to wonder if the patients looked at in this series really are the same patients that we're seeing and treating in the clinic every day. And then finally, there's no data on the clinical status of these patients. And certainly earlier on, was there a bias for taking sicker patients to PCI or higher risk lesions, even if the patient was stable to getting PCI. So whether or not PCI is actually protective or harmful, I think we still need some more work. So terrifyingly, this is a patient of mine who developed SCAD after sneezing. And you can see that she has a type 1 dissection in the mid-LAD there. And 4 months and 6 left heart caths later, she now has a near full metal jacket in her LAD. And so she had 1 stent when she left the hospital, but over time needed more and more interventions. And it turns out that when we look at the Mayo Clinic series, the patients who were treated with PCI, primarily PCI initially, ended up needing more target vessel revascularization compared to those who were treated conservatively. And that was stable over time. And why is that? It's because these lesions, as I've shown you, tend to be very, very long and require lots and lots of stents. And so the longer your stent length, the more stents you use, increases your chances of developing some instant restenosis and thrombosis. So these patients can present with angina, and it's not a new SCAD, it's actually instant restenosis. There's also this phenomenon of undersizing. So when you have that intramural hematoma and you've got that mass that's been squashed on the walls, all of a sudden at 30 days, you've got intramural hematoma resorption, and the stent that was well-sized in the acute period is now too small. And so these patients can present again with stent complications and not necessarily recurrence. So what about the effect of revascularization on recurrence of SCAD? It turns out that there's absolutely no change in recurrence of SCAD based upon whether or not you were initially treated medically or treated with percutaneous intervention. And why is that? It's because recurrence tends to occur in a different vessel than the first SCAD happened. This is data that is scary to patients and to doctors, but I think if the justification for putting in a stent is to prevent recurrence, then that's not actually a good reason. What is the rate of recurrence? And one of the things we have to do is separate the terminology. So there's true recurrence, where a patient has a heart attack and they develop new chest pain and a different lesion. That's a true recurrence of SCAD, versus extension, which we often see in the hospital, where patients will be treated medically or with a stent, and that during that same hospitalization, they'll have recurrent chest pain, a bump in their troponins. You take them back to the lab, and all of a sudden, your LAD lesion, which only affected a small portion of the mid-LAD, has now propagated. And so I would consider that an extension. If we consider recurrence to be separated temporally and also anatomically from the original lesion, we see that in the Mayo series, it's about 27% over 5 years. In the Vancouver series, it's about 10% over 3 years. So the rates of recurrence are actually not insignificant. Jackie further looked in her registry, and keep in mind this is retrospective data, but the two variables that ended up making a difference in recurrence were whether or not a patient was being treated with a beta blocker and whether or not a patient had hypertension, which was controlled. And so for this reason, some are advocating the use of beta blockers in all SCAD patients who were able to tolerate them. So now I want to take you out of the hospital and bring you into the clinic, where I see the majority of my SCAD patients. This is a 45-year-old woman who has no significant cardiac history. She's actually a lab technician in the hospital. She develops acute chest pain at work, walks herself down to her local emergency department, and is diagnosed with a non-STEMI. She undergoes coronary angiography, and I think everyone can see that she has this abrupt tapering of her LAD all the way down to the apex. PCI was attempted, but because there was no appearance change in the LAD lesion with balloon angioplasty, the angiographers, the interventionalists, decided to stop and treat her medically with dual antiplatelet therapy. So then she was referred to me to establish cardiology care. So in my brain, I ask myself some clinical questions when I see a patient like this. Are any further evaluations necessary? What types of history do I need to obtain to counsel the patient? Are there any physical exam findings that I need to be looking for? Are there lab tests that I need to order to help explain why she had this spontaneous dissection and MI? What imaging tests do I need to order, if any? And do I need to consult genetics? Is this a weird genetic disorder? So I think these types of questions that run in my head before I walk into the clinic really get to some root questions of, is SCAD really a disease in isolation, or does it involve other arteries? What is the etiology of SCAD? And if present, how do I diagnose these extracoronary abnormalities? Is SCAD a genetic disorder? So getting to SCAD being a disease in isolation, one of my very first patients when I started as staff at Cleveland Clinic, probably 9 years ago, in the vascular medicine clinic, this woman had presented with chest pain, diagnosed with non-STEMI, was sent home, came back, developed chest pain while she was vacuuming, presented again to the same ER. She had significant EKG changes, and what looked like abrupt cutoffs in multiple arteries, was sent to bypass surgery, and they felt that she actually had a hypercoagulable condition. So she was sent to me for anticoagulation advice and a hypercoagulability workup. But when I did my physical exam, she was so musical. She had bruits in her neck, in her abdomen, in her groin. And this was before all the connections with SCAD and FMD were found. And lo and behold, we find FMD of the bilateral renal arteries and this significant complete loop in her left internal carotid artery. So is SCAD a disease in isolation? Well, I just showed you that picture, so probably not. In 2005, Chris Bueller's group in Canada, over a span of a week, they were on call, and during that week, they had 3 patients who were young Caucasian women without cardiovascular risk factors who presented with MI in the middle of the night. And they found this very unusual lesion where the film showed the caliber of the artery, the coronary artery, to be normal, and then there was this abrupt narrowing. And for some reason, they were doing drive-by renals. I'm not really sure why they were looking at the renal arteries, but they found multifocal fibromuscular dysplasia. And so this is actually the first publication showing coronary dissection next to an image of fibromuscular dysplasia. And these were 7 women with acute coronary syndrome. They went on to accumulate cases and look retrospectively also at their other cases. And the authors proposed that this was the coronary appearance of FMD. Interestingly, they say in their paper, coronary dissection is a condition that we considered. None of the patients demonstrated angiographic findings of a double lumen, spiral lucency, or contrast staining. So this was 2005, and so you can imagine that before this, really, this dye staining was the definition of SCAD, and even the authors who present SCAD next to FMD didn't recognize it as SCAD. So no, SCAD is not a disease in isolation, and Jackie Saw is actually in the same group as Chris Bueller, and she is an expert in OCT, and so she actually demonstrated that these skinny, narrow lesions are actually intramural hematoma with or without an intimal tear. And I'm sorry that you can't see my mouse. Oh, there it is. And you can see that here you can see an intimal defect, but here you can't. And that corresponds to here and to here. So what is the prevalence of extracoronary findings in these 2 large cohorts? If you look at the Canadian cohort, only 86% of patients had complete screening from head to pelvis. But of those who did, 72% had FMD, and about 10% had a cerebral aneurysm. If you look at the Mayo cohort, consisting of about 115 patients, 72% had complete screening, and of those, 52% had FMD. A smaller proportion of them had cerebral imaging, and 23% had brain aneurysm. But Mayo is not including anatomy above the ear until recently, and so these patients had other reasons for intracranial imaging, and so that prevalence number is probably skewed a little high. We do have some older histopathologic evidence that SCAD is a manifestation of coronary FMD. This is actually a cross-sectional gross microscopic image of an LAD of a 26-year-old woman who died from myocardial infarction. And what you can see is marked intimal hyperplasia here. So she had fibromuscular dysplasia displayed in her coronary arteries. This is another image in a 24-year-old man who was in the hospital and septic and very sick for other reasons, and ultimately died from a coronary dissection in his RCA and LAD. But you can see that he had fibromuscular dysplasia changes in the coronary artery, and in one image you can see dissecting hematoma, intimal disruption here, but also changes of fibromuscular dysplasia on the same image. And so there is some evidence that perhaps SCAD and FMD run together. Well, can you see FMD angiographically? So most of us, when we think about FMD, are thinking of the multifocal type, that classic string of pearls. But it turns out that in the coronary arteries, that classic string of pearls is really, really uncommon, rare to see. What we see most commonly is the coronary artery that's undergone what I call a perm. It's very curly, very tortuous. And some of these patients actually have, significant loops in their coronary arteries. Some of them have pseudoaneurysms. Some of them have these unusual webs. But coronary tortuosity is something that multiple groups have demonstrated in these patients. So Jackie Saul also published on OCT work, and what she did was she performed OCT in patients who had FMD in non-coronary distributions, who had an indication for coronary angiography, or she looked in the non-affected vessels of patients who had SCAD previously. And what she found was very interesting. So she actually saw some hyperplasia, she saw some loss of elastic membrane, she saw duplication of elastic membrane, she saw some deposition of unusual, what she called proteoglycans. You also see neovascularization and cavitation. And so these arteries in these patients with FMD are certainly not normal. So we've been talking about FMD a lot. You have Brian here, and he's given grand rounds on FMD before. So I don't really have to go into very much depth, but I thought I would give sort of a brief review as it pertains to SCAD and sort of how to think about patients in the clinic. So FMD is a non-inflammatory, non-atherosclerotic disease of the arteries, really of unknown cause. And it can cause, in addition to stenosis, aneurysm, dissection, and arterial tortuosity. It used to be that you had to have a piece of the artery to look under the microscope, but because of histopathologic angiographic correlation work that was done very early on at the Cleveland Clinic, it's really primarily an angiographic diagnosis. And because it was a histopathologic diagnosis in the past, when we referred to FMD, we would refer to it as medial fibroplasia, medial hyperplasia, intimal type, adventitial type, but that's really kind of confusing. And so new nomenclature has been proposed where the string of beads is multifocal and everything else is focal. And FMD can present as a single concentric stenosis or a smooth tapered narrowing. And so unlike atherosclerosis, where you often see stenosis right at the ostium of the vessel and often have plaque protruding into the aorta even, when you have a young person with a smooth concentric stenosis about a centimeter away from the ostium, think fibromuscular dysplasia. And so when we refer to FMD, if you see string of beads, it's multifocal. And if you see that smooth narrowing, single lesion, call it focal. And like SCAD, FMD is not an isolated arteriopathy. And while the renal distribution we all learn about in medical school, so young women who presents with hypertension, who doesn't have otherwise other risk factors for hypertension, the test answer is think about fibromuscular dysplasia. But it turns out that carotid FMD is almost nearly as prevalent as renal FMD. And I tell my patients who present to me with renal or carotid FMD that there's this 2/3 rule. If you've got carotid FMD, 2/3 of the time you'll have renal FMD and vice versa. If you have a patient with SCAD or a patient with FMD and you listen for bruits, if you hear a bruit, it's probably pretty sensitive for detecting FMD using an imaging modality. But if you don't hear it, it doesn't rule it out. And so it becomes important to look for other involvement because these patients can have aneurysm, dissection, et cetera, in other places. And involvement of more than one vascular bed is really the rule and not the exception. So who gets FMD? Well, these demographics look very similar to those of patients who get SCAD. It's middle-aged women, primarily women. And in FMD, the diagnosis has a significant delay, on average about 4 years. And why is that? Because patients present with symptoms that are fairly common and mundane. They have hypertension, they have headaches. But if you have a woman who has severe migraine headaches and they say they hear a swooshing noise in their ears, then the swooshing noise sounds like So it's literally that sound you hear when a sonographer does a carotid ultrasound. That's what they hear in their heads. You have to think about fibromuscular dysplasia. Other really common symptoms of cervical FMD are neck pain, as well as some dizziness. This is a patient's sister of mine. So I had a patient with known FMD who came from West Virginia to establish care with me, and her sister had come with her, and her sister, who was very beautiful, blonde, stick-thin, athletic woman, said, I was just diagnosed with high blood pressure last week, and I have no idea why. And so while she was there, I listened to her, and lo and behold, she had bruises everywhere. And so we ended up checking her in for a visit, and she actually had FMD in multiple vascular beds. She had renal FMD, she had iliac FMD, she even had a vertebral pseudoaneurysm that she didn't know about before. And her, if you listen to her, she had been suffering from migraine headaches for several years, and her hypertension, like I said before, it was sort of out of the blue for being a younger, very fit woman. So what do we need to think about in terms of FMD, and why do we need to worry about the diagnosis? It's because there are some complications that run along with FMD that should not be ignored. The most recent FMD registry data shows that over 20% of patients with FMD have at least one aneurysm somewhere. A quarter of patients have at least one dissection. And if you put them all together, over 40% of patients in the registry have had a dissection or an aneurysm. So FMD isn't just a disease that causes hypertension and migraine headaches. It actually causes aneurysms, which need to be put under surveillance, and dissections, which certainly can cause an organ damage. And as I'm getting to, FMD is a morbid disease. Patients with FMD have significant major vascular events, and certainly there is referral bias. It's the people who've had events and get diagnosed who get put into the registries. But even with that caveat, these numbers are still fairly high for patients who are otherwise healthy. And in patients with FMD, such as those with SCAD, the rates of arterial complications as a result of procedures is much higher than one would expect in patients who are otherwise healthy. And so there really is something about them that predisposes them to aneurysms and dissections. And unfortunately, we haven't gotten to the bottom of why that is. So I think that FMD affects at least half of patients, or we can detect FMD in at least half of patients who have SCAD, and up to maybe 3/4. There's some debate about the best diagnostic modality for FMD. There's no genetic test, there's no biomarker, so perhaps that number is higher. But not all SCAD is from FMD. This is one of my very last patients at Cleveland Clinic before I left for Vanderbilt. She was a 39-year-old woman who was eating lunch with her friend. She was 5 months postpartum. She developed acute onset chest discomfort that she tried to sort of let time pass but didn't, went to the ER, had a positive troponin, was diagnosed with a non-STEMI, went for coronary angiography, and ultimately had been referred to the heart failure clinic because she was diagnosed with Takotsubo cardiomyopathy. So my colleague in heart failure looked at her coronary angiograms and said, wait a minute, that doesn't look normal, and sent her to me instead. And this is, I think everyone recognizes by now, is type 2 SCAD. So in talking to her and trying to get a review of systems, she said that at the time of her chest pain, she also developed a severe left-sided headache. And ever since she had her cath performed, and incidentally her cath was performed through the radial, she could no longer exercise because every time she tried to exercise or go any length, she would develop right lower extremity claudication. So we imaged her, and she actually ended up having a left vertebral dissection and pseudoaneurysm. And when we get ABIs, we see that the right ABI is 0.7 compared to her left, which is 1.15. And I think everyone can recognize that her lesion is somewhere in the SFA popliteal region. And she went on to have CTA, which did diagnose the presence of a distal SFA dissection as well. So when you take a family history, she says, well, my father has heart failure, and he was diagnosed with a dilated non-ischemic cardiomyopathy. Her father and her sister actually had repair for pectus excavatum, and she actually had a first cousin who had Marfan's. The patient herself met none of the Ghent criteria for Marfan's, but her family history is certainly compelling. And she was sent to genetics along with her family, and I don't know what it showed because I left the Cleveland Clinic, so I'm sorry. This is another patient of mine. Here is a CTA image, and you can see that there is a lesion there in the LAD. She has a past medical history that was significant for chest pain at the age of 40, and she underwent coronary angiogram. At 49, she had a saccular aneurysm of her hepatic artery and received a stent graft to that. At age 50, she had branch dissections and aneurysms of her superior mesenteric artery and a failed percutaneous intervention of that vessel. At age 53, she was diagnosed with an internal carotid artery aneurysm. And at age 54, she was emergently taken to the OR for a spontaneous splenic artery rupture. And quite obviously, she had something wrong with her, was sent to genetics, and she tested positive for the COL3A1 mutation, which is the mutation that goes along with vascular Ehlers-Danlos, which is associated with spontaneous dissections and aneurysms in patients without atherosclerotic disease. And you can see on her CTA that, you know, her chest pain at age 40 is probably a coronary dissection, because now we're seeing this pseudoaneurysm in her LAD. So one of the million-dollar questions is, why does SCAD happen? And I've compiled this table from the world's literature, as sparse as it may be. So the most commonly implicated disease that goes along with SCAD is FMD. So 45 to 86% of the time, if you look, you'll find FMD. But the second most common cause is idiopathic, meaning we have no idea. There isn't any other disease that goes along with it. There wasn't a stressful event. People weren't postpartum. And then all of these other causes that have been implicated, hormonal therapy, multiparity, inflammatory disease, precipitating stressors, it's very hard to get a worldwide prevalence of how many people are actually taking hormonal therapy and how many actually have had more than 4 births. And keeping in mind these are women, like, is this really just reflective of the population, or really is there an association? And then people always say, oh, there was a precipitating stressor, but I think having a heart attack is a stressor itself. And so you have to wonder how much of this is recall bias. People are always wondering, like, what did I do to cause my heart attack? So I'm not sure that there has to be a stressful event that has to go with SCAD. You know, as in some of these examples I showed you, people were driving, they were singing in church, they were eating lunch with their friends. And while pregnancy-associated SCAD in the older literature was a significant cause of SCAD, less than 5% of patients in modern registries are actually in the peripartum period. So how do you screen for extracoronary abnormalities? I hope I have sort of convinced you that SCAD is not a disease in isolation. And our job in the clinic is to not take care of just the coronary dissection, but also think about the other vasculature. And in my practice at the institutions that I've been at, CTA is, the technology is just better than the MRAs. And so I've been using CTA from head to pelvis. I've worked with my radiologists so that patients can get a CTA from head to pelvis in one go. I'm not sure of the technicalities of that, but they only need to come once, and we can look at the brain all the way down to the iliac arteries. And what is the yield of doing that type of thing? We looked at our own data at the Cleveland Clinic, and it turns out if you have a patient who has FMD, let's say of their renal arteries, and you scan them from head to pelvis, or even just from chest, abdomen, pelvis, half of the time you'll find new beating, 20% of the time you'll find a new aneurysm, and 3% of the time we found a new dissection. So screening is actually very high yield in this population. And then going on from there, once you've identified which territories have been affected identify this arteriopathy, we tend to use ultrasound to follow these lesions over time to see if there's been any change. But there are some people who the FMD is in areas that you can't diagnose with just a screening CTA head to pelvis. And this is an example of patient with brachial FMD. And I know there's been more and more images in the interventional literature lately because we're doing more radial access. But this patient just had a bruit in their upper arm. And when we look with ultrasound, there's classic beading. And so if a patient has SCAD, I actually listen to the arm as well. And if there's a bruit, I look. And I know there are some in the FMD community who do CTA head to pelvis and also ultrasound of the arm as well for screening. So a SCAD genetic disorder, probably, and FMD is probably a genetic disorder, but it's probably not a monogenic, autosomal dominant or autosomal recessive disorder. It's probably very complex. If you ask a patient with SCAD if they have a family member with SCAD, only 1.2% of patients will answer yes, although SCAD's difficult to diagnose, and so who knows if that number is actually an underestimate. There has been reported to be FMD noted in a pair of first cousins who've expressed SCAD, and in my own practice, I've had a mother and 2 daughters with FMD and 1 daughter with SCAD. And so there probably is some genetic undertones in that family. However, there's been no specific genetic loci for SCAD identified. And we also know that SCAD's been reported in conditions with known Mendelian inheritance, but these are the minority of patients. And so Marfan syndrome and Loeys-Dietz, if a patient with SCAD comes in and I screen them and they have a dilated aorta, that's actually not a common finding. And if they have a dilated aorta, I send them to genetics to screen for aortopathies that can actually give us a clue about underlying susceptibility. And then the one to really remember on the differential diagnosis for anybody who has a spontaneous dissection anywhere is vascular Ehlers-Danlos, because the medications we use would be very different for this population. The surveillance we use is very different, and then certainly you never want to do any type of elective invasive procedures in patients with vascular EDS. We actually had an abstract at ACC, and what we did is we asked our SCAD patients if they had a family history of any of these vascular findings. And if we look just at aneurysm, it turns out that if you ask a patient with SCAD, do you have anybody in your family with aneurysm, first or second degree relatives, about a quarter of them will say yes. And that finding was independent of whether or not FMD was present. And our numbers were really too small to have a significant p-value. But I think that this is another indication that SCAD and FMD are not diseases in isolation, and that patients probably have variant presentations of an arterial disease that binds these families together, but they may have different presentations. So one may have an aneurysm, another may have a dissection, another one may look like FMD. So how do I approach these patients in my clinic? I take a very careful personal history. Was this SCAD iatrogenic or really was it spontaneous? I take a very careful family history and try to go back and see if there is other aneurysm or dissection, early heart attack in other members of the family. I love the physical exam in my FMD and SCAD clinic because if you listen, you will hear. These bruits are really interesting to hear, and it's like a kid in a candy store. I listen from head to pelvis. So bilateral carotids, subclavians, brachials, renals, iliacs, and mesenterics as well. And then I quickly look for connective tissue disease physical exam findings. So do they have the classic craniofacial abnormalities of Loeys-Dietz or Marfan's? Is the uvula normal? So certainly if you see a bifid uvula and you've got a dilated aorta, you have to think about Loeys-Dietz. Do they have a high arch palate? Do they have a pectus, excavatum, or carinatum? Do they have scoliosis? Are their wounds funny? Do they have Horner syndrome, which could make you think about prior carotid dissection? This is a patient of mine at Vanderbilt, and it's hard to see, but can you guys see that she actually has a bifid uvula there? So I'm probably the only cardiologist at Vanderbilt who actually looks at the uvula, but I think it's important because it can give you clues as to what else is going on. So if a patient has multiple arterial beds that are involved with dissection and aneurysm, or they've got an aorta that's involved, or they're very stretchy or have a very significant family history, I do send them to medical genetics to consider a conversation about screening for aortopathies and vascular EDS. And why is this important? It's because we treat these patients differently. If they've got underlying aortopathies that are genetically mediated, certainly our threshold for fixing them is different. In patients with vascular EDS, we really have to think about holding off on all elective procedures. There's family planning involved. There's a lot that you can get from genetic information. And vascular EDS, contrary to the classic connective tissue EDS where you see these people that can stretch their skin really far and have large joint hypermobility where they can take their legs and put it behind their ears. Turns out vascular EDS is not really like that. So they have these sort of elven faces. They have small joint hypermobility, but they're not really stretchy like you would see in the movies. They do have velvety soft skin though. So you hear some practitioners say when they walk into a room of a patient with vascular Ehlers-Danlos, they know right away because when you shake their hands are so smooth and soft. And then one of the most common questions I get asked by patients and by other doctors is, what happens to life after SCAD? And I think one of the most important things that we can do for ourselves and our patients is to send them to cardiac rehab. Chest pain after SCAD is so common, and some of it is actual angina, and some of it is pain that happens because of things going on between the ears. And when a patient goes to cardiac rehab, they're monitored. And so it reassures the patient they're able to exercise again, and it reassures me that they're able to exercise again without having ischemia that is evident. So I send all patients to cardiac rehab, and we talk about dissection precautions. So I tell them no heavy lifting. So anything that causes them to turn red in the face when they lift it, or anything where they can't talk through the lifting, they probably should avoid. And when they do weights in the gym, you're going more, for like the runner's body or the soccer body rather than the weightlifter body. So lighter weights at multiple reps. Certainly no more roller coasters. I tell them when you see a sign that says talk to your doctor about whether you can do this because of heart problems, you've talked to your doctor, and I've said no. Because these are young people. These are young women who have children and they go to Disney World. And it's not necessarily I'm afraid that they're going to have a coronary dissection, but the other arteries. There's a lot of jostling of the neck that goes on and abrupt starts and stops. And then we talk about competitive sports. We really don't recommend competitive sports in these patients, but we tell them, you can run the 5K, just don't win it. So it's not that they can't do activity anymore, it's just they can't do it to the intensity that they were doing before. And in the end, this may all be hogwash. We have no data to support this, but I think it's just common sense. These patients have an underlying arteriopathy and a predisposition, and so we just want to be careful because they have many decades of life to live. And coming very soon, I wanted to let you know that there is a scientific statement on SCAD that'll be published later this month, and I was one of the co-chairs on this document, so a lot of this will be sort of rehashed in that document. We have a lot of work to be done. Let's face it, our patients really deserve more. The state of research on SCAD is really in its infancy. It's really limited to case reports and single center registries. And the largest published cohort up to now only includes about 300 patients. No clinical trials exist. Funding for a rare disease is really difficult to obtain. Infrequent events require really large numbers of patients for adequate power, and we really have to work together because no one person can see enough patients to be able to make a real difference quickly. There are so many questions in this disease, going all the way from the general prevalence of the disease to the natural history and whether or not patients can go to the gym and exercise. And so it's really important for patients to have adequate support. So if you have a rare disease, it's not something you did to yourself, and it's a really traumatic event, it's very reassuring for them meet people who have the same disease. And so there are patient organizations. I'm on the scientific advisory board for SCAD Alliance, which is that patient advocacy group started by Catherine Leon, who I showed you earlier. And certainly Brian and I are both centers for the FMD registry. And the SCAD Alliance is actually funding the iSCAD registry. And we have 13 medical centers who are signed up already to become a part of this multi-center registry. And our hope is to be able to recruit patients very quickly so that we can answer some of these important questions. Patient support in this disease is so important. And I know Brian's had some FMD-related patient support type of events here. This is one I did at Vanderbilt this August. It was just this little conference I put together, and I had some of my neurosurgery colleagues talk about brain aneurysms. I had a migraine specialist there. I had, our interventional cardiologist there, and we had a patient panel. We had 80 people from 14 states come to Nashville for this little tiny thing. And so you can just see that patients are so desperate to just even meet one other person who's had this and know that they're not alone. This is Jessica Biggs that I showed you earlier. You can tell we're sisters from other misters, right? So it's really important to provide these patients the reassurance that, yes, I'm not really sure what the natural history of this is, but you're not alone and we're working on it. So in summary, SCAD is rare, but it's probably underdiagnosed. And accurate diagnosis is critical because it makes an effect on treatment and whether or not you need to look for other arterial diagnoses. More than half of the time, SCAD really is not an isolated disease. You have to use all of your clinical tools, your radiographic tools to make the diagnosis of non-coronary vascular disease and be prepared to provide the patient with basic answers and resources to help them cope. Thanks very much.
Thanks so much, Esther. I think we have time for a few quick questions. If there are any, otherwise, I'm sure we have a few minutes. Esther will be at the podium if you want to come up and discuss. But thanks so much for providing that insight on SCAD and FMD, and I'll give it to the audience if you have any quick questions.
Esther, great talk.
Thanks, Luke.
We see some of these folks are vascular, and one of the things that we've been counseled is to make sure that they have their life insurance before genetic counseling. Is that a real deal, that they won't be able to get life insurance if they have that?
I'm not really sure, but that's what I've heard as well. And so that's why I don't do the genetic testing myself. I don't draw their blood for COL3A1. I actually have them talk to the genetic counselor first to talk about insurance issues, implications for family planning, and implications for other family members before they get any of that drawn, because you're right, it's completely life-changing.
My finger never works. Oh, thank you so much for that. So I was looking for my interventional colleagues who actually do the work. I'm not saying I see one or two, but the big problem exists. You made the point that treating them medically is the right thing to do, right? If you see a STEMI, you got a SCAD, boom, try to treat them medically. I was in Canada last month, and they showed me a case of a patient with not only LAD occlusion due to SCAD, but ongoing ischemia and hemodynamic compromise. So they stuck, right? So they put a stent and the LAD opened up. And as you've shown, subsequently, a day or two later, extension of this. Patient's now on the transplant list up there. But it occurred to me that you have to open these up. Stents are a bad idea, and nobody's working on something else. We used to have something called a perfusion balloon. We used to have these temporary things. You got to restore flow. Is anybody giving any idea to some temporary intervention that could stop the heart attack, but at the same time not result in this a bad late outcome?
I'd love to learn more about that technology that you're talking about, but no, I mean, I've had several patients who were sort of expectantly managed on balloon pump. to just get rid of symptoms. And I had one woman who was on balloon pump for almost a week, but she was able to successfully come off. But there are patients who ultimately require transplant. I know Jackie Saw is starting some experience with using cutting balloons to try to just relieve the pressure in the intramural hematoma. But I can see how that can be nerve-wracking for some patients or for some interventionalists to do that. But there is no, specific SCAD-related temporary measure that's been developed or tested.
Yeah, the cutting balloon was used a few times in Edmonton, where I was, for this, and it's been reported in cases. But the idea that we know STEMI with acute occluded artery results in a heart attack. The treatment is restore blood flow. How can you restore blood flow at the same time not get trouble? And I think this is an area for investigation that might involve some new technology.
Absolutely.
Can I just one more quick one? So your thesis is that SCAD is probably more of a systemic disease and greater involvement. Have people looked at the sort of vascular mechanics of these patients outside of the coronaries, looked at their arterial compliance? And I mean, certainly the beating and all suggests sort of axial stress issues, et cetera.
So there have been some brachial artery reactivity testing performed in patients with carotid dissection and has shown that there's been some differences in patients with carotid dissection versus not, but nobody has published on that type of testing in SCAD. There have been some work in IMT in carotid FMD as well, but that's only one study. So no one's done a deep dive into the physiology and the mechanics. And that's something that if someone here is interested in doing, the field is ripe for more research. Great, thanks very much.
The preceding program is copyrighted by Emory University.